Welcome back. Welcome to the last session of this virtual meeting on lessons learned from the pandemic, redesigning clinical care, research and public health. We've heard a lot of information in the last 3.5 hours of webinar. And in this last session, we'll try to take that information and look forward and try and ask the question, are we ready for the next pandemic? And what it is that we have to do to accelerate and implement that readiness. We have a brilliant set of speakers and panelists. We'll first hear two introductory talks, one from Professor Charlotte Summers, who is the Dadelet Heart and Lung Research Institute Director and Professor of Intensive Care Medicine at the University of Cambridge in the UK, on how we embed lessons learned in the everyday work in medicine and public health. And then we'll have a presentation on the ongoing processes internationally at global level. In Geneva, New York, we've heard already a bit of that in the last 2 days by Nina Schwalbe, who is a major global health and public health figure who served in a number of organizations, who is a lifetime member of the Council of Foreign Relations in the US and currently serves as Principal Visiting Fellow at the United Nations International Institute for Global Health and affiliated with Spark Street's advisors in the United States. And then we'll have a panel discussion with two additional speakers that I will introduce as we move into the discussion. So it's my pleasure now to give the floor to Professor Charlotte Summers.
Thank you very much, Michel. So I am Charlotte, as introduced. I'm a clinical academic in respiratory and intensive care medicine in the UK, and I'm not what would be normally considered part of the public health community in a sort of a global sense. I am someone who practices at the bedside as well as running a research group looking at how we develop mechanistic insights for therapies that can make patients better. So I'm coming to this problem from a very clinical perspective rather than necessarily a global public health one. So with the question that I was set kindly by the organisers of this meeting, the place I wanted to start with it is, what is the everyday work of healthcare? And I'm not sure that health systems across the world necessarily are clear about what they think it is. And what do I mean by that? What I mean is healthcare actually the prevention, diagnosis and treatment of disease, which is very much an ill health or disease-focused system? Is that what we're looking at? Or is it actually about supporting individuals and populations to attain a state of complete physical, mental and social well-being, and not merely the absence of disease, as the WHO has suggested? And I'm not sure necessarily that individual health systems across the world have reconciled them to whether they're providing a disease system or a health system. And so thinking about our everyday work, we probably need to do a bit more work on thinking about what our actual purpose is and what we're trying to attain. There's been a lot of talk about the depoliticisation of healthcare and that perhaps we need to think about building for the future healthcare that is separate and not interfered by politics. But I want to highlight that I think healthcare, however we deliver it and however we define it, is not delivered in a vacuum. It is not a discrete entity in and of itself. Health and well-being depends on education, it depends on housing, employment, political and social environment in which we are delivering that, because actually our politicians and our social society determine the budgets, they determine our priorities, and in democracies, we vote for these people. So they are part of the system and the context in which we are delivering health and well-being. air quality, global heating, conflict, and a whole host of other things impact on the delivery of healthcare, but also on health and well-being itself. So we don't deliver healthcare in an unconnected way. If we're thinking about building for the future and making healthcare better and embedding pandemic preparedness in health, we need to think about embedding it in all of these elements, in whether we can make social and political society more favourable, improve housing, education, climate, all of these things. We cannot just do it by tackling health alone in terms of healthcare delivery. And when I thought long and hard about what is the one thing that actually everything comes down to about the delivery of health, from me at the bedside asking one of the relatives of one of my patients who's profoundly unwell that I need to put them on a mechanical ventilator because they've got multi-organ failure, through to vaccination, to all kinds of aspects of the thing that we call health. Actually, trust is at the core of every single one of those relationships and conversations and things that we build. And I know that Scott talked about health earlier on and trust, and I wanted to revisit that theme. So what is trust and how has it been impaired and what do we need to build? And I think there's calls for both pessimism and optimism in this slide that comes from the Edelman Trust Index that I know you saw some data from earlier. Institutional leaders, certainly in the 2023 data set, suggest that some types of them are less trusted than they have been. So government leaders had a net decrease in the amount that they were trusted, and they're still very much untrusted. So are journalists, and so are CEOs of companies. However, people were more trusting, actually, of the people in their own local community, of their individual CEO that they know and work for, as opposed to CEOs in general, their co-workers, so the things that they come into contact with their community, but also, interestingly, scientists. There was a net increase of 1 point in trust of science between 2022 and 2023. And whilst there has been much said about scientists and loss of trust in science and leadership, actually, there's optimism too. It's not potentially quite as bad as maybe it's discussed. You know, we're still not down there with journalists or government leaders as yet. But that's an average of how people feel about trust. There is a really clear divide along socioeconomic lines about how people trust organisations. And I think this is one of the things that we need to bridge going forwards for the future. So this slide shows what the kind of trust is across nations, the Global 27 included in this survey, for the top 25% of people with income in those settings and the bottom 25 in those. And you can see the average trust of organisations, so NGOs, governments, business and other sectors. If your income and your socioeconomic status is lower, you are less trusting of those organisations than if you are of more higher means. So we're not all living in one society in the way that we might think. So the approaches and the things that we need to think about to build trust are very, very different for different sections of our communities. Ipsos Mori also have looked at some data around trust and have done a similar kind of global approach to doing surveys as Edelman do. And actually, they've looked at what types of organisations people have trust in. And interestingly, out of the organisations they asked, pharmaceutical companies were at the top. Which I was surprised about in this data, because given a lot of what the social media and other discourse that happens in the public domain is that we can't trust drug companies. There's been a huge amount of it, particularly in the pandemic. However, actually, they were the top rated above tech companies, food and drink, retail, all of the others. They were the most trusted. However, across nations, it's not stable. And you'll see that some areas of the world, like China and India, have got much greater trust in pharmaceutical industry than perhaps places like France and the UK. So again, we are not all thinking about trust and understanding trust in a unified way across the globe, how we view our communities and our relationships are impacted by the ecosystem in which we live, by our political and social climate. So the solutions that we come up with are going to have to be bespoke for the communities in which we're trying to target. So how do we build trust? And this is so hard. But I think, again, there's some data that could help us. The Ipsos Mori poll asked people, of the 2 or 3 attributes, tell us what it is that makes you want to trust organizations. And the number one thing is, if people say what they say they're going to do, they do. So do they keep their promises? Are they reliable? And we'll come back to that. They value transparency and openness. They behave responsibly, and they provide good value for money. It's actually only the 4th ranked. People care a lot more about transparency and whether we deliver when we say we're going to when thinking about organizations. So I think some of the things that we need to build and we need to develop are data-based, in that we know what people think about when they think about whether something is trusting or not. But I think what it all boils down to is this. Trust is built with our actions, not our words. And this is where, particularly in the COVID pandemic, but also in historic pandemics before that, trust has been broken where people's actions and organizations' actions have not aligned with their words or their purported values. And I think that until we actually can address this and try and have organizations showing leadership whose actions and values align with the things they say, we're going to struggle. But what should we be aiming at when we're building trust? And I wanted to highlight this because there's been a lot of talk about equality and equity and liberation. And I think for me, this particular image shows exactly what we should be aiming at. Equality is not enough. If we give everybody the same thing, so everybody has access to a vaccine, that is not good enough, because what is needed by the individual societies and the individual communities which we are trying to help either prevent, diagnose and treat their health issues or get this state of overall well-being, depending on which approach we take philosophically from the beginning, they need different solutions. So what is needed in the UK is very different to what is needed in China, to what's very different to what's needed in Uganda. But better than all of that, we need to be working to remove the barriers, not just provide people with stepping stools on which they can stand to overcome them. We need to be trying to take away the barriers that people face. We've talked a lot about vaccines, particularly over the last couple of days, and I wanted to highlight another issue that actually has been more long-standing, perhaps, than around the issues we've had with COVID vaccines, and it's about a really simple therapy, so oxygen. Oxygen has been on the WHO's list of priority medicines for more than a decade at the start of the pandemic. For decades and decades, children under 5 and particularly women actually have died from lack of oxygen every single year. And yet, very little action has happened about oxygen. We haven't treated it in the same way as we have perhaps treated other therapies or even thought about it. But oxygen became a particular pinch point during the pandemic for all societies. And to highlight that, I've taken some press clippings about oxygen across all sorts of health settings to explain that trust was broken because of the failure for us to be able to deliver this really simple thing to people that didn't think they'd ever have to worry about it. So, for example, in New York, the top headline saying some hospitals are facing an oxygen shortage amid a coronavirus crisis. Hospitals in New York had oxygen shortages that meant there wasn't enough for all the patients that they had. The same thing happened in the UK. A Hertfordshire hospital had to have its intensive care unit evacuated on a Saturday afternoon because the oxygen stopped coming out of the wall because they had so many sick patients. The same thing happened in India. It was on the news very regularly, and this is a BBC clipping. People died every single day because they could not get the simple life-saving therapy of oxygen. They weren't anywhere near having tocilizumab or dexamethasone or a whole host of other therapies. They didn't have oxygen. And actually, the WHO highlighted that actually more than 500,000 people and low and middle incomes every day were struggling with lack of oxygen. Now, there was more strain on the system because of the pandemic and the greater incidence of people requiring oxygen, but this is not a new problem. This is a problem that we have failed to address for many, many decades. And to illustrate some of this, some data from some collaborators that I've worked with. So we had looked at people who presented to Malago Hospital in Uganda in November 2015 to 2017. And we looked at all adults who were admitted to the medical emergency department who had oxygen saturations of less than 92% and said that they were acutely short of breath. So they had shortness of breath for the last week and no longer than that. Everybody got standard oxygen therapy, which was they got up to 4 litres of oxygen to keep oxygen a minute, to keep their sats above 92 if you possibly could. And we followed up the people and said, what happened to this cohort of people? Because there was no data on emergency acute hypoxic respiratory failure in this setting. Well, we screened 7,300 people, and 328 of them were admitted to hospital. The median age of these people was 38. Their saturations on admission, the median saturation was 77%. 77% of them died in hospital, and 85% of them were dead within 90 days. Now, there are very few health settings in the world in which 85% of 38-year-olds dying within 90 days is acceptable. 82% of them were thought to have pneumonia. And actually, interestingly, only 30% of them had HIV and less than half of them had TB. Most of these people were young people dying of community-acquired pneumonia, an entirely preventable disease, and with supportive care that could make it better. This is not a new thing. We have failed to address it before the pandemic, let alone in the pandemic. We were quite shocked about this single centre data. We're like, well, maybe this is something about Malago, maybe we should have a look and see. And so we started actually having planned in 2019 to do a study across Uganda. We also hit the pandemic period, but still managed to actually do a study where we looked at 39,000 people who were presenting to hospitals across Uganda. And again, they were presenting with acute shortness of breath, and saturations of 92% or lower, and were thought to be acutely unwell, not due to trauma. So we had a cohort of about 800 of people, and essentially what we found was that the median age of these people in the bigger cohort was 50. Their saturations were a little bit better at 88, and we wonder whether people were presenting slightly earlier in the pandemic because people were more aware of COVID. They were aware that they might need healthcare, and there was different infrastructure in place to when we'd done the original work. The 28-day mortality, however, was still 37.9%. So this is 50-year-olds. 15% of them received high-flow nasal oxygen or non-invasive ventilation or invasive mechanical ventilation at any point. But 20% of them never received any oxygen therapy at all. So this is 20% of people whose oxygen saturations were less than 92% due to acute illness at the time they presented. 1 in 5 of them didn't get access to oxygen therapy. Lung infection was the most common cause. And as you can see, that was their probability of survival over the days. So people died pretty rapidly, so in the first 10 to 14 days, and then it plateaued off. We were unable to do the 90-day follow-up in quite the disseminated cohort that we'd done before in the middle of the pandemic, so we only managed out to 28 days. In September 2022, there was a Lancet Global Health Commission on Medical Oxygen Security launched. And there's been a lot of talk about oxygen and how we need to make it better. And actually, there was adoption of the Medical Oxygen Resolution in May 2023. And so there's been lots of words spoken about oxygen security and making sure that this essential medicine is available to everybody going forwards. But we haven't delivered the action yet, and we need to make sure that our actions align with our words. So how do we embed lessons learned in the everyday work of healthcare, and had a few thoughts about how we might do that. I think we need to turn up. And by turn up, I mean there is a global issue around healthcare workers of all types actually leaving the professions and the roles in which they work. But we also need to turn up at a societal and a public health level too. If we do not commit to doing the work that's required outside pandemics and only turn up when there's a problem, we do not build the trust that is needed. We have to stand alongside and work with and support communities between pandemics every single day. It is hard work, but trust is only built over time. And I know as an intensive care physician that building trust in an emergency is not the time to be doing it. Trust in systems and that people are going to help them needs to be built over time. We need to acknowledge that health is multidimensional and is impacted by our surrounding ecosystem, so by the politics and the housing and the global heating and the other things that we are exposed to every single day. And we need to build trust by our actions, and I think I've made that point already. We need to focus on equity and removing barriers, which can be termed liberation. And we need to get the basics right. I think it's very hard to ask people to trust us when they have been saying, my child has been dying of oxygen, or my wife didn't have access to oxygen so that she could have surgery to have our baby, or even able to have an anaesthetic in the first place because there is no oxygen available. And then say, but you need to trust us to take this other thing that we've developed and we really want you to have, when their everyday experience is not that we don't have access to the basics and we don't appear to care about it. And we need to be honest about uncertainties and commit to learning what does and does not work. And this is really hard anytime, but particularly in pandemics. I think healthcare professionals and politicians throughout the strain of the pandemic were not always honest about uncertainty. And we didn't all do everything we could to commit to learning what does and does not work. And by that, for me, it means embedding research and finding out what does and doesn't work as a strategy, whether that's about health communication or about vaccines or about clinical trials for therapies. We need to build the infrastructure that says, we don't know now, but we could. And there I was going to stop.
Thank you very much, Charlotte. Thank you, brilliant. Thank you for bringing the issue of oxygen. Thank you for bringing this message on words and actions. And thank you for bringing the perspective of a clinician. I know that many clinicians are actually in our audience. So thank you very much. So let's move now from the bedside to the global world and see what's going on. Where is the global effort in trying to avoid the next pandemic and avoid that we face again the tragedy we faced with COVID-19? So it's a pleasure for me to introduce now Nina Schwalbe. Nina, the floor is yours.
Hi, good afternoon. I'm excited to be here today to talk to you about pandemic governance and the instruments currently being discussed and processes on the table to improve it. There are three main processes currently underway. The first is a high-level political declaration, the first ever on pandemic preparedness and response. The second is a new treaty, or what's called a pandemic accord, which is being negotiated by an international negotiating body in Geneva. And the third is an amendment to the international health regulations, amendment to the protocols, which were last amended in 2005. These three processes serve quite different purposes. The first, as its name suggests, is a high-level political declaration. It's a political process at the heads of state level to agree on how to prepare for future global health threats. IHR, the purpose of the international health regulations, it's a protocol already in place, it's legally binding, and the aim is to prevent and control international spread of disease. And the third is the pandemic accord. And the purpose here is to strengthen global collaboration. I like to think of the three, at least in my own mind, as the high-level political declaration is a rah-rah moment to get member states at their highest level, at their head of state level, to commit to doing something different next time and to working together to do it. The IHR is technical. It's technical capacities that every member state has to have in place in order to help prevent and control the spread of disease. And the third is more of a principles, but with some concrete commitments where states commit to each other about how they're going to do better next time. IHR has been in place for a long time, and it's legally binding, and it requires that countries have the ability to detect, assess, report, and respond to public health emergencies of international concern. That is not necessarily pandemics. It's a call made by the World Health Organization, made by the head of the World Health Organization. And the idea is that he or she makes a call as to whether something that is an infectious disease outbreak has the potential to be something a lot more serious and also to spread to neighboring countries. Within the IHR, countries commit to a number of things. They commit to surveillance technologies. They commit to particular abilities and capacities within their public health system. And they also commit to have a focal point who's responsible for this. Most importantly is that they're obliged, when they have a suspicious outbreak or an event with potential of spreading, that they notify WHO within 24 hours. And then WHO makes the call as to whether or not this is a public health emergency of international concern. Since 2005, as you can see from the slide, WHO has declared a number of fakes, public health emergencies of international concern: H1N1, polio, Ebola, Zika, COVID, and even more recently, monkeypox. As I mentioned, right now there's a technical group, a technical revision underway, and it's actually moving relatively smoothly. And the idea is to bring back a revision to this document for adoption by the World Health Assembly in 2024. So that leads us into the Pandemic Accord, and negotiations are currently underway. So what is the Pandemic Accord? The idea is that it will be a binding instrument which commits member states to act in certain ways if and when there's a pandemic. So this is different from a public health emergency of international concern. This is about a pandemic, and it's about how do countries, member states, prepare for, prevent, and respond to pandemics. And right now there's an interesting discussion on redefining what is a pandemic, redefining what is a public health emergency of international concern, but we won't go into that right now. So let's assume, for the sake of this argument, for the sake of this presentation, that pandemic is defined. The process was first called for in May of 2021, finalized through a special meeting of the World Health Assembly in November, December of 2021, and a group called the Intergovernmental Negotiating Body, which is essentially member states, was tasked with negotiating this instrument. It will be, it's developed under the WHO Constitution. WHO has a constitution. WHO's voting members are member states, represented by their ministries of health. And it will require ratification to enter into force. And what that means is that once it's agreed at the World Health Assembly, member states have a certain amount of time or period of time in their own national legislatures to ratify this treaty into action. I use the word treaty, but I use that a little bit lightly. Right now, the INB, which it's called, the Intergovernmental Negotiating Body, is discussing exactly what this instrument will look like. There are a few different options under Article 19, conventions, frameworks, agreements, and treaties, and they all have slightly different implications. Right now, it looks like they may be heading towards a framework agreement, which means that the big principles will be laid out without all the details, and then the details will follow in individual protocols. And the idea is that this draft will be negotiated and finalized by May 2024. We'll come back to the timelines in a couple of slides. So what is it? What's in this document, and what is it trying to achieve? Well, we don't actually know yet. There have been a couple of first drafts. There was a first draft, then there was a compilation draft, and a compilation draft means all the member states put in their comments and their paragraphs and their language. Then there was a new draft, which the Bureau produced. The Bureau is sort of the secretariat, if you will, of the intergovernmental negotiating body. And now they're doubling down, taking lots of feedback. They had lots of working groups, informal working groups, to discuss sticky points over the summer and up until through September 22nd. And now the Bureau is working on a new draft, which will be shared on October 16th, or not later than October 16th. But what we know from the previous drafts is that the text is pretty comprehensive. It has language about supporting prevention and detection of outbreaks with pandemic potential. So this is about the prevention part. It talks a lot about how states can better and faster and more effectively coordinate in terms of their response. A big issue, as you know, during COVID-19 was the lack of equitable access to pandemic countermeasures. So rich countries stood first in line, leaving low-income countries far behind in the queue for masks, vaccines, just about everything required for the response. Equity is a principle that everybody agreed to, which was nice, North and South, that next time the response has to be more equitable. And that is a discussion that primarily hinges around the countermeasures, but not only. One thing that was felt to be very, very unfair in terms of the pandemic response was when South Africa identified the Omicron variant and then was essentially punished for sharing their data and information through trade and other restrictions. Data sharing is a really important part of this. How do we better, faster, more quickly share data, samples, genomic data? How do we do this technically in terms of interoperability? But more importantly, how do we do it fairly so that people who provide information are compensated for the information that they provide, and also get information back. So it's not just a question of, again, low-income countries providing data to high-income countries that then make vaccines and profit out of it. It's about really more equitable benefit sharing. And that's a term that you'll hear, equitable benefit sharing. And finally, more attention to One Health. And what One Health is it's the intersection between humans, animals, and their environment. And as we know, a lot of these diseases of recent, the ones that have been declared fakes, actually have resulted from spillover from animals to humans. So in the public health community, we tend to focus on the humans, and the Accord is going to help us double down so that we are also focusing on the animal-human interaction. So the issue about the Accord is, how do you enforce it once it's there? This has been a problem for all treaties, really, and there are a couple of ways that it can be done better. So the agreement, once it's signed and once it's ratified, enters into force. There's a conference of parties, which means member states, a committee, that's what it's called, who oversee the implementation of the treaty. States will self-report, as they do with the IHR. There's provisions for peer review. We're also proposing an independent monitoring committee. And just as an example, if we look at the IHR reporting, and this is the blue box at the side of the slide, there's a report that we identified, a WHO report, that says 100% of state parties reported, and then the fine print is within the last 9 years. And the question is within the last 9 years enough to really hold states accountable? So we're proposing an independent monitoring committee which would assess state reporting, really do three very basic and simple things. The timeliness of the reports submitted by the state. So this is agnostic of what is in the treaty. There will be commitments to certain aspects of things that member states will do. So we're saying we'd like a committee that looks at the timeliness, the completeness, and the accuracy of these reports. And when reports are not accurate, is able to escalate those or not completed on time, or not comprehensive, not complete. They can escalate those both to the Conference of Parties, which governs the treaty, as well as to UN member states through the UNGA. And the idea is that the UNGA is more than ministers of health. It's really political leadership. It's represented, heads of state represent governments at the UN General Assembly. Also, these reports would be made public. And the idea as well behind these reports is that they could focus on other sources. We know that Twitter has been a major source of information, for better or for worse, and wherever Twitter's going. But what we mean is civil society, public reporting, public citizens. There are other ways of getting information to test whether or not something is going on in a country. And that goes really back to the China example, which is, had there been other means of verification, for example, that disease outbreak, would we have been able to move faster in terms of a response? And there are lots of examples of how this is done in other treaty bodies. Human rights has a whole shadow reporting system. The Atomic Energy Treaty allows for march-in, so countries can be visited if the Atomic Energy body feels there's something amiss. So lots of examples of this. So finally, as we mentioned on the next steps for the pandemic, the process began in the spring of 2021. The new draft is about to be released on the 16th of October. Then negotiations begin starting in November on the actual text, with the idea that by the end of March, they'll have a draft which is adoptable by the World Health Assembly in May. So thank you for your time, and excited to hear from you. If you want more information on what's happening in sort of real time in these negotiations, check us out on Twitter, because we try to keep everybody up to date. Thank you.
Thank you very much, Nina. I believe it's very important that everyone in our audience is sort of updated on these processes. Let's move now to our panel. And we're joined, I can see, by Joanne Liu and Sylvie Briand. Thank you, Sylvie. Thank you, Joanne. Dr. Sylvie Briand is the director of the Epidemic and Pandemic Preparedness and Prevention Department at the World Health Organization headquarters in Geneva. And Joanne Liu is a pediatric emergency physician who is a professor at McGill's University. She's been the international president of Médecins Sans Frontières, Doctors Without Borders, during the Ebola, at the time of the Ebola pandemic. And she's recently served as a member of the independent panel that has been mentioned quite often during these few hours of seminar that we have been having. So welcome to all. And since this is the sort of concluding session of our webinar, I thought that rather than asking you to provide us with more elements, I'd like us to try and come to some sort of synthesis of where we are, where we're going. Are you optimistic, pessimistic? So we entitled the session, Are we ready for the next pandemic? Or I'd like to say, are we ready also to prevent that the next infectious outbreak with a new agent becomes a pandemic? And also, what will be different for the next pandemic or for the next outbreak with pandemic potential? And so the next half hour or so will be just you with your own background. Charlotte, your clinical background. Nina, your public health background. Sylvie, your WHO background. Joanne, your fantastic experience in the field, providing genuinely your perspective on this issue and on the question. So let's start with a round of sort of first remarks, maybe 5-7 minutes each, no more. Thank you. And let's start with you, Sylvie.
Thank you very much, Michel. And yeah, I would like to highlight that I've been at WHO for many years now, and I've been part of the response of most of the epidemics and pandemics of this century. And so I've learned a great deal of these crises in the meantime. So I hope that I can reflect on the last one, but also highlight what has changed in the past decades. I think COVID-19 has had an enormous impact on health with 770 million cases and 6.9 million deaths, but also has had an impact, of course, as you know, on economies, with, according to the IMF, probable an estimated loss of 12.5 trillion between 2022 and 2024. And but I think one of the major loss and or impact of COVID-19 has also been on society, with a very important growing distrust in authorities, science, even if it's not as huge as we thought, and it was mentioned by the previous speaker, but still, I think this mistrust or distrust is really empowering social cohesiveness, and we will have to rebuild the trust for the coming years. And I think we need for this to have a slightly different approach than the traditional public health approach for preparedness. The second issue, I think, of this crisis has been really the enormous amount of evaluation and assessments and reports that have been produced. And we have received at WHO more than 300 recommendations for how to do better next time. And so we have tried to group those recommendations into three main areas. One is strengthening global governance, and it's a leadership, inclusivity, and accountability. Strengthening financing to have sustainable, coordinated, and innovative financing, and strengthening systems. And here I will focus a lot on strengthening systems because we don't have much time. And we have developed a framework for this called HEPR, Health Emergency Preparedness, Prevention, and Response. And that covers 5 main areas, 5 C's. The first area is collaborative surveillance. And on this, I would say that we need to understand better our enemies. I mean, those emerging viruses and or parasite or bacteria. But the enemy is a pathogen, and we need to understand them better and use technological progress to really do this faster and better at the initial crisis. And I think we need to leverage technological progress, such as, for example, wastewater surveillance, genomic sequencing, and ensure that those capacities are available everywhere on the planet and not only just in rich countries, if we really want to have a global approach to pandemic. In addition, for collaborative surveillance, I think we need to foster a cross-sectoral approach for surveillance. And one good example is the One Health approach across between animal health, environmental health, and human health, and share data across those sectors to improve surveillance and detection of emerging pathogens. And finally, I think on collaborative surveillance, we absolutely need to maintain the gain. There have been a lot of improvement in capacities in surveillance in many countries during pandemic. Unfortunately, now governments are stopping the funding of those surveillance capacities. And so we anticipate that laboratories that were able, for example, to do genomic sequencing will not be able to do it anymore in the coming months because they have no finance to do so. The second C is community protection. And I think here I would like to focus on really the new information ecosystem in which we are living and the threats that is represented by mis and disinformation. But we have proposed at WHO to call it infodemic management because we prefer to focus on understanding this new information ecosystem and promote approaches that will increase the resilience of community to mis and disinformation rather than targeting only pieces of information that are inaccurate. Because we have seen during this pandemic that if you could focus only on debunking inaccurate information, in reality, you are fueling conspiracy theories. And so it's exactly the opposite that we wanted to have. So we need to really revisit how we manage information during crisis and how we empower and engage communities in managing this new information ecosystem. The third C is care. And I think we have seen, and Charlotte mentioned it earlier, that care, we need also to revisit how we see care in emergency. And for me, I think we need really to focus on treatment. Although I think vaccine is a very important tool for managing pandemic and epidemic, but vaccine, it will always take time to develop a vaccine, especially if it's a new pathogen. So I think we should also foster more research on therapeutics and, for example, antivirals, but also test and treat approach for outpatients, and not only focusing on therapeutics that can be used in hospitals, because very often when people reach the hospital, they are already in severe conditions, and most of the time treatments are inefficient at that stage. So, and the second thing on care, I think we need to empower healthcare workers, because they have been seen as a trusted source of information. And so we need to help them to be a better information provider to communities, and build this trust that is really needed during crisis. And finally, I think we need to protect health workers, because many of them have died during this pandemic. It's unacceptable, in my opinion, and we should make sure that our health system, that are already quite weak, can be much better prepared for next time, and this goes through protecting the health workforce. The fourth C is access to countermeasure, and really ensuring that there is equitable access to those countermeasures, be it vaccine, treatments, or diagnostics. Even if 70.5% of the global population has received at least one dose of COVID-19 vaccine, this percentage is reduced to 32.6% in low and middle income countries. So clearly, we are not there is no fair and equitable access to those countermeasures. And we need really to build those mechanisms before crisis, because we know that during crisis, usually when you have scarce resources, is either first come, first serve, or the richest get it all at the beginning. So we need to put in place those things. Recently, we organized during the high-level at the margin of the UN Assembly, a ministerial breakfast, and we invited civil society organization to speak. And really, they highlighted the fact that, of course, the international partners are pushing for instance, for reducing the time to develop new countermeasures, like the 100-day mission that has been promoted by the G7 countries. But the CSOs highlighted that what is the point of making rapidly vaccine treatment and diagnostic if the population doesn't want it? So we need also, again, to build trust in the population in those countermeasures, to make sure that people will use them when they need them. And finally, it's emergency coordination. And I will not talk too much about it, because Nina already highlighted the three ongoing processes: the revision of the International Health Regulation, the development of the Pandemic Accord, and also the adoption very recently of a political declaration. But I just would like to highlight that personally, I have a lot of hope in those processes, because it allows countries to discuss what are the issues with pandemic preparedness, prevention, and response. And I know that the world is very fragmented, that we have currently a lot of geopolitical tension, but frankly, if health could be the space where people continue to discuss and try to find a solution together, I think this is already a good thing for the future. And I hope this will enable us to be better protected. Thank you very much.
Thank you, Sylvie. You know, we've been discussing trust a lot during the last hours of webinar. If there is one institution in which I believe there is strong trust across the world, it is the World Health Organization. So we're really all looking at you. But then let me ask you, what would be your estimate of how long will it take to actually become reasonably prepared for the next pandemic? We can't hear you, Sylvie. Yep.
I think that preparedness is a process. It's a process. I mean, you are never prepared, fully prepared, and that's why we need to embed preparedness in the health system strengthening, but just have in preparing for the next crisis, just understand that we need to build a strong health system. Always try to have a stronger health system, and just make sure that those health systems or our societies are resilient to crisis. And so it's more an approach to revisiting just the way we are operating and the way we are implementing or going through or towards a sustainable development goal, and making sure that in this journey we also understand that there will be crisis, and how we can, while we are progressing towards a sustainable development goal, how we can embed in this journey the relevant elements that will enable us to be more resilient to crisis. Just a very concrete example, for instance, most of the health system in developed countries are built for treating a chronic disease, and most of these countries are forgotten that we still can have epidemics even in wealthy countries. And so how are we going to organize our health system to make sure that, for instance, they can isolate patients during an epidemic without stopping the functioning of the entire hospital and stopping surgery for other disease or other urgent care that are needed. So these are just very concrete examples, but I think we can really improve in the way we are prepared to deal with infectious disease in the future.
Yes, thank you. I take your point that preparedness is a continuous process, and such, and the same is true, and it goes with health system strengthening. But many of the evaluations, including that of the independent panel, of course, have called for transformative changes, real transformative changes, in order for us to be better prepared. And this is why I was asking my question about the timeline, because this is not about a continuous process. This is about the political decision of all of us coming together and saying, no, we do have to change things. So thank you very much, Sylvie. Please stay with us, of course, yes? And let me turn now to Nina to hear your perspective. And let me say, Nina, I received a question from someone in the audience saying, why have so many speakers during the last hours of our webinar expressed disappointment with the September political declaration?
Great, thank you, Michel. I think I'll start with the question. It's an excellent question. Well, first of all, there was very little high-level showing. It was a high-level meeting, and the point was to get heads of state on board to say, pandemics are more than health, we care, and we're going to do things differently next time. And actually less than 15 heads of state showed up to the meeting. So that was very disappointing for people. I think the idea was as well to have a short, concise, action-oriented document. And as you mentioned, there was only one action that came out of that document, which was to meet again. So those are in 3 years' time, which people feel, I think, is a little late if a pandemic hits us tomorrow. So I think those are just two of many reasons why people felt disappointed. If you also wanted me to reflect a little bit, I'd like to reflect a little bit on things that I've heard that I think, I don't want to say I'm pessimistic, but I'm certainly not optimistic. So I won't pretend to be. But there are a couple of things that I think we need to do radically different and sooner rather than later. You know, Sylvie referred in her talk to something that she called the traditional public health approaches. And I think this was a major misstep, is that in most schools of public health, as we know, And the way that students, and I hope many of the people on this webinar are taught in public health, is that the very nature of public health is that it's cross-disciplinary. And we have lawyers, and we have activists, and we have sociologists, and we have anthropologists, and we have historians. And that's the wonder and breadth of a public health response. And during COVID-19, we became very epidemiologically focused. And the things that started to matter to people were surveillance, epidemiologists. If you look at kind of who got the airtime, and the rest of the public health ecosystem, which is so important to what Charlotte was talking about building trust. How do we work and think and talk to communities? How do we engage with communities? That part of public health was really left out. So I hope one action that comes out of all of this is next time we make sure that the next time there's an emergency, all of the different disciplines of public health are brought into the room. The second point I want to make is about trust. And again, many of the speakers this morning talked about trust. That's an area where I still think we're not there. We did a study in New York City and showed that in the first few months of the vaccine being available, even though it was only supposed to be going to the elderly, in districts in New York City with rich districts, rich part of the cities, we had over 70% of that entire part of the city vaccinated, when in theory, it was only supposed to be going to people over the age of 60. So I think this thing about equitable distribution and database decision-making and what we call precision public health, which is getting interventions to the most vulnerable, we still aren't there yet in terms of a commitment to prioritize it. And the third thing that I think would make me more optimistic, and really reflecting on the wonderful conversations that I've heard so far over the last 2 days, is some straight talk among all of us. We're not all agreed on what was good, what was bad, what went wrong, what didn't. And I think we need a lot more conversations, honest conversations about why we thought different things. We all came from very different perspectives. Lockdown in New York City was different from lockdown in Cape Town, was different from lockdown in Lusaka. So I think we need a lot more honest conversations as public health professionals about where we got it right, where we got it wrong, both personally and individually, as well as a community. Thanks.
Thank you very much, Nina. Thank you for those thoughtful comments and about the multi-stakeholder or multidisciplinary basis for public health. Maybe I'll turn again for a second to Sylvie. How much is the World Health Organization capable of mobilizing this breadth of actors? Because there is this debate about whether the solutions are to come from Geneva somehow and WHO, or should they be taken up in New York by the broader political community, reflecting maybe the broader number of actors and decision makers that should contribute to finding solutions.
Well, I fully agree with Nina that a proper response to this kind of crisis should be a whole of society approach because everybody's impacted by pandemics. And so we cannot just rely on the health sector to conduct the response. However, I think this is the kind of linkages and approaches that we need to build between crises. So that we ensure that during crisis, we have also the proper communication channels and the proper leverage to communicate with those other sectors. So during this pandemic, for instance, WHO has created networks, for example, with the faith-based organization, with the world of work, so with the private sector and industry and to protect workers around the world. And they are happy also to coalesce around WHO because let's say what triggers a crisis is still a disease. The trigger is a disease, and there is a strong response needed from the health sector. So I think it's important to acknowledge that we need also to address the health crisis, and not only but with a multi-sectoral approach. The other thing I think it's very important is that you don't start a pandemic with a pandemic. I mean, usually it starts with a small event, a localized outbreak, and then if we are not able to contain it, then it becomes a pandemic. And so I think that's why it's very important also to understand this dynamic, because we don't start working when it's a pandemic. We start to leverage all those connections with other sectors, even for very localized outbreak. And I'm sure that Joanne Liu can comment on this. When MSF was responding to Ebola outbreaks, for instance, we have engaged other sectors at that time, and we have tried really to not only address the particular issue of the Ebola disease, but also try to understand the impact on those communities and address the needs of those communities, like with food or security at the same time. Thank you.
Thank you, Sylvie. And of course, you're absolutely right. One of the slogans of the independent panel in our communication has always been, in the future, let's stop outbreaks where and when they occur. Of course, we don't want to be in that situation of the pandemic anymore. Charlotte, I'll turn to you now. And maybe with the same question, and following up on what Nina has been saying, and Sylvie, what's your perspective?
So I think I share a lot of what Nina and Sylvie have said, in that I think to be prepared in future, there are various categories of things that we need to have a plan for. But I think we also need to accept the adage that every single plan ever made fails with first contact with the enemy. So we need to agree principles and values and accept that any planning we make needs to be flexible enough to cope with the thing that we didn't see coming when crisis arises. I think very, very importantly, Sylvie pointed out about the importance of staff and healthcare workers. We need to have resilience and support for healthcare workers, that we have enough people to do those roles. Across the globe, people are deciding to go and do other jobs because they don't feel safe doing the roles that they've done, and they don't feel valued. And we do need to accept that we didn't get everything right. People did die who should have been protected to provide care for other people. It's very difficult to ask people to lay down their lives for the good of other people when they feel that they were failed and that they were preventable deaths. So I think we do need to acknowledge that and commit to doing better. But I think we also need to think about testing capacity, which we've talked about. We need to think about therapies and not just vaccines, because actually therapies and supportive care, not just therapies to change the fundamentals of the disease, all have to be in place from the beginning. And we have a broad guess. It's fairly easy to imagine some of what we might need. Some of it isn't. Antivirals, we've been trying for effective antivirals for a range of diseases for decades, and we're not there yet. She said, thinking about a potential coming flu season in her own country. But we could be. And I think there's a lot of work we can do between pandemics to address those deficits. And I think, again, coming back to the trust and agreeing, what do we as a society think are the important values that we want to hold on to in times of crisis, as well as the rest of the time? Because when systems are stressed, people start making choices that they wouldn't necessarily make otherwise. They choose themselves and their communities over the people that are next door or different to them or somewhere across the globe that they have not met. So we need to think about the fundamental values that we hold and build a plan that's based on those. There's lots of reasons for pessimism, but I'm optimistic too. If you look back from where we've come from to where we were for this pandemic, actually there were signs of things that we did better than we had before. In terms of the research response and finding effective vaccines and effective therapies, we generated actionable insights from healthcare research in timeframes we would have thought were impossible previously. Thinking about the UK response, the recovery trial found that dexamethasone worked inside 100 days from the trial starting, and it saved lives. It saved more than 1 million lives, the estimates are, in the first 9 months. We couldn't have done that the year before outside a pandemic, let alone. So I think we have to acknowledge successes as well as the things that we didn't get right. So I'm optimistic, but we're losing ground at the moment, or at least that's how it feels from the kind of clinical setting. And I'm really, really anxious that we build rather than lose ground.
Thank you very much, Charlotte. Let me just ask you very briefly to answer a question that is coming and which is obviously directed to you. It says in one of the slides, it was optimistically mentioned by the presenter that the trust to the scientists has increased. But the problem is that many anti-vaxxers and anti-COVIDists are scientists with PhD, high titles, several high-profile institutions. So this slide can be interpreted differently.
So one of the things I think we have to acknowledge is that healthcare professionals and scientists did not always cover ourselves in glory during the pandemic. People advocated that vaccines did not work or were harmful, that therapies that there is no evidence of benefit for were the cures for COVID. Scientists and healthcare workers are human. They are as valuable as every other bit of society, and so putting them on pedestals and allowing ourselves to be put on pedestals is not helpful. I think that data gave me optimism in that they had asked broader society across 23 countries how they felt in between 2022 and 2023 about scientists, and there was a 1-point increase in trust. I think sometimes it's easy for us to get lost in the everything's terrible, it's all really bad, and not necessarily acknowledge that actually it might not be as bad as we think. We could be politicians, we could be journalists.
Thank you. So let me now turn to you, Joanne, for your perspective. And thank you for being with us. It's early morning, I guess, still in Canada.
Good day, everybody. Well, fantastic intervention from all the panelists, and I'm happy to meet all of you all again. Well, my perspective, I think, from I'm a biased speaker from a humanitarian background, and so thank you to mention, Sylvie, that we were together in Ebola, and let me bridge some aspect of this with what we're going through. Because in your question, Michelle, am I optimistic? I would say that I'm sort of a cautious optimistic person. And why am I a cautious optimistic person? Is because the fact that when Ebola in 2014, 2016 happened, I think all the key lessons about how to manage at generic level an epidemic was there. And it's because it was very, very graphic. Everybody, it was an existential threat. And then we saw how it was, I would say, perturbing society. And then just to remind people, it was the biggest Ebola outbreak, 28,000 cases, 11,000 people died in West Africa, and mostly in 3 countries, Sierra Leone, Guinea, and Liberia. So in terms of what I'm trying to say is I'm cautious because I think that some of the lessons from Ebola, although there were 20 commissioned, were not, implemented the recommendation. And so either we're slow learner, either we have a learning disability, or possibly as well tied to that, attention deficit disorder at political level. So I'm a pediatrician, so I always have those kind of link. But that being said, let's talk about the positive thing. We have improved things. For Ebola, it took 6 months to declare a public health emergency of international concern. For COVID, it took 6 weeks. During the Ebola, we did R&D, research and development clinical trials at the tail end of the outbreak. And then with COVID-19, we did at the peak, and then we were on the starting block. And then that was one of the key lesson learned from Ebola. And in that aspect, WHO was really in the driving seat for that. We have to say as well that we tried to come together as imperfectly as it was. The world tried to come together. And then we created an imperfect platform, but that tried to do something, which was the ACTA. And so somehow, things improve. But I think one of the things we still forgot, which are the very, very basic for me, if your response is not faster than the propagation of the virus, my God, you're gonna be in there, for a long ultra marathon on barefoot. So you really have, and this is why implementing and learning, it's important. But we, as I said, we having problem with that. So, but I think that slowing down the virus was a key thing, and we have to remember though this caveat is like for Ebola, we said do not close the border because and then for COVID-19 with an 180 degrees. So we try to adapt. So it's easy, to complain and to criticize, but I must say there were some I would say some attenuator. The other thing for me was the big thing is the political will, because if it was not of the fact that the world came together to a certain extent for Ebola, it would have been hard to finish that outbreak. And so I think that this is something that we hardly were able to address initially in a meaningful way. Everybody thought it was something from far. Initially, everybody was looking what was happening in China, and then for the month after the declaration, the public health emergency of international concern, most of the Western countries basically were in the wait and see mode, and then wondering what will happen. And they finally switched gear when we declared the pandemic WHO in March 11, 2020. So I think these are the thing I wanted to bring at the forefront, and at personal level, because this is something that's really close to my heart, because I was there in West Africa, is about safe funeral, dignified funeral, and the need for ritual for people to come to closure. We learn it there, and as well the fact of not letting people dying alone. We learn it there, and we could not translate that in meaningful action during COVID-19 in the initial months. We didn't tackle it afterwards, but this is something that we could not enact. And so I'm cautiously optimistic about that. And that was the reason why I was on the IPPPR, on the independent panel. And then for us, our big thing was, let's be this COVID-19 a Chernobyl moment. When was the last time we put our life on hold for more than 20 months? When was the last time that we let our elders, dying alone, talking to them on an iPad? When was the last time that we have to stay home, for different, family gathering? We did that online. And I don't want to go thoroughly, to the recommendation of the IPPR, but I want to really bring back, the idea why, because to respond to Sylvie, why the independent panel insisted on the political leadership and then possibly having what we call a global threat council is, I strongly believe that you need the political, I would say, support to bring the attention on an issue, sustain it, and as well this will unleash resources, and then so therefore will bring to the WHO what it needs to do, what they have to do. So for me, it is key. I think we've discussed extensively about the medical countermeasure and being accessible, and but the thing is to look at it. It's for us, the mindset is about creating common goods, and it's how we define it. Everybody talks about equity. Nobody talks about COVID-19 without saying that in their speech. But how do we walk the talk of equity for everybody and not only for one part of the world? And so, so this is what I wanted to say mostly. I wanted to make a small comment on the financing as well, because we may want to talk a lot of about what we want to do, but if we don't finance it, And then right now it's a failure. You know, we're asking for 10 billion a year for financement, for prevention and prep, and we only have, you know, a fraction of that. And this is on a yearly basis. And this is to save probably trillion if we were to be hit again by a pandemic. And so, and then the other more technical aspect were addressed, you know, through the presentation of Nina for the recommendation of the IPPR. So I won't go forward on this. But I think that we learned that as well in this pandemic, that the human being is a survivor. And so, as you know, you said it, many of you in different ways, is the fact that when there's going to be scarce resources, when we're going to feel our life threatened, well, we're going to try to save our life. And so the first casualty of pandemic for me, it's our solidarity. Thank you.
Thank you very much, Joanne. It's about time to close this panel and end this webinar. Joanne said that the world came together somehow. You said imperfectly maybe, but the world came together. I think at the end of this session, I'd like to say that it's not time for the world to now return into different directions. It's time to stay together, because now is the time to prepare, as Sylvie has emphasized. Now it's time to prevent outbreaks from becoming epidemics and from becoming pandemics with increased surveillance, local, regional capacity to respond to outbreaks. It is time for the world to enter with strong commitment into the international discussions that are ongoing. And despite the challenges that we would like, as Nina pointed out, so much that they succeed. So let us not miss this opportunity. Let us have COVID-19 be the last pandemic of that size and of that tragic dimension. Thank you all very, very much. Thank you to all of the speakers today. Thank you to all of the speakers throughout these 2 days. Thank you to my co-chairs, Dan, Jeff, Nikki. Thank you to our sponsors, and thank you to Moderna, who provided an unearmarked grant to this event, and other sponsors that we now see on and supporters on the slide. Please do fill the survey that is sent to you electronically. Thank you for joining us. Thank you for attending. And preparing for the next pandemic is the job of all of us, whoever we are, wherever we are. I know there's a very diverse group of people who have joined this seminar. All of you are important in all of us, again, making together COVID-19 be the last pandemic. Thank you.